We are indebted to the following pharmaceutical companies for the financial support they've provided towards the costs of CL support conferences. They have no input in the content of the programme or the choice of speakers. And they have provided monies which are used towards the cost of the venue, the catering, and meeting the costs and the meeting costs, and also to make a professionally edited recording available on our YouTube and channel and our website. And those companies are AbbVie, AstraZeneca, BeiGene, now known as B1, Johnson & Johnson, and Lilly. Professor Adrian Bloor is from the Christie. He trained in haematology at Cambridge University and at the University College Hospital in London before moving to Manchester in 2006 to take up a consultant post in hemo-oncology. He has a special interest in the management of lymphoid malignancies, both CLL and lymphoma, and is director of the Christie Stem Cell Transplant Programme. And he's also principal or chief investigator for a large number of trials and stem cell transplantation in the Leeds CLL Trials Management Group. He's also on the UK CLL Forum Executive Committee and medical advisory panels to the Lymphoma Association and Blood Cancer UK.
So I've got two talks today. One is around essentials of CLL. The other, I've changed the title a bit. It's more around, as I was putting this together, it's around first-line treatment decisions in the talk I'll give after the coffee break, rather than going too much into multiple lines of therapy. I am happy to cover whatever in terms of whether it's trials, esoteric things, transplantation, CAR T therapy, whatever, but not something I'm going to cover today in the interest of trying to give some breadth to this. So just in terms of background, the blood and lymphatic system, and really taking it back to basics in terms of when we talk about CLL, what is it that we're talking about, where do things come from? And just a reminder that all of your blood, everyone's blood, starts in your bone marrow and it originates from stem cells. Stem cells are cells that have the unlimited capacity for growth and differentiation. So they turn themselves over, so it's the engine in your bone marrow making cells, and they are also capable of differentiation, both into blood cells but also into other types of cells. So the broad distinction in terms of blood cell development is from stem cells, which can then differentiate in what are called myeloid cells. This is red cells, platelets, monocytes, neutrophils, and I'm not going to talk about those, and then lymphoid cells, and they can go through various stages of development. So people ask in terms of what does it mean in terms of lymphoid cells and the complexity for things. So lymphocytes, white blood cells, start in the bone marrow. So they are born as lymphoblasts. So these are cells that are going down that lymphoid origin, and they grow quickly. Then they work their way out into the blood, into the lymph nodes. Now this is an important concept here because the function of lymphocytes is to be part of your immune system. And it's a random process. We make loads and loads of lymphocytes every day, and then your body selects the best fit for those lymphocytes against whatever we're seeing in the environment. That then makes cells that are specific to fight a thing, and then they come out into your blood. And they go through different stages. Some cells are designed at different phases to be in the lymph nodes, some to be in the bone marrow, some to be in the blood. And some will grow quickly and some will grow slowly. And so cancer, including CLL, is where a cell becomes immortalized at a point in time. And it remembers a bit about what it was supposed to be doing. So a cell that's immortalized in the bone marrow at a lymphoblast grows quickly and becomes acute leukemia. It grows a very rapidly proliferating disease. A cell that's sitting in the peripheral blood, waiting around to be doing something when it's required, is a slow-growing cell, and this is more about what CLL is. So this is why there are distinctions about things, but it also adds to the complexity, because as you divide that step of blood development into more and more and more steps, you can have more and more and more types of lymphoma or leukemia that can arise as a result of it. And so in terms of the lymphatic system, where do lymphocytes reside? Well, they're all over your body. They're in your blood and they're in your bone marrow, so therefore they can be everywhere. But the dominant places where lymphocytes reside are in the lymphatic system for here, which you've got, where's the pointer? No. The red. No, I have red. There we go, red. So, lymph glands. People say, where are my lymph glands? Well, they're in your neck. You can feel them. Sides of your neck, above your collarbones, under your arms, in the crease of your legs. But you've also got lymphocytes and lymph glands that run all the way through your body, and they run in a chain. Kind of imagine going down the back and then in front of the spine all the way down and then down your legs. And so this is where the lymphatic system is. But there are also other parts of it that can be in your spleen, which is like a big lymph gland sitting under your ribs on the left-hand side. The thymus in your chest, that's more to do with T cells, so not really anything that's important in CLL development. And then other places such as in your bowel and in your skin. And so CLL is where these cells they grow abnormally, and they're predominant in your blood. They can be in all of these places. And this is what CLL cells look like under a microscope. And so this is a blood film, and you can see here red cells. These are all abnormal lymphocytes, and these are what are called smear cells. So you may see this or hear about this. You have a blood film that's done. It says it's got smear cells. They don't really mean anything. When you make a blood smear to look at under a microscope, you put a drop of blood on a slide and you squish it to separate it. And the CLL cells are a bit fragile, and so they just turn into these smear cells. They're just squished up cells, but they're because the reflection of the fact that the CLL cells are not completely normal, and they grow too quickly. So why do people get cancer? People say to me, I'm completely well. I live a good life. It's perfect. I don't smoke, I don't drink. No one in my family's had cancer. Why me? Why have I got this? Well, I always put it back in terms of actually why doesn't everyone get cancer? And in fact, it is part of this that actually development of cancer is part of the aging process. If you go back to the 19th century, when life expectancy in the grim north was 30-something, the causes of death were infection and occupational injury. Because nobody lived long enough to get cancer. Cancer's existed forever, but actually cancer, including CLL, is almost like a disease of the 20th century. As people start to live longer, then you have more propensity to make cancer cells. And there's this continuous equilibrium. Just to sort of walk you through this, this is designed to illustrate the development of non-blood cancers. So if you imagine that this is the lining of your bowel, for example, called the epithelium, and it ticks along and it's okay, but it's always under stress and it's proliferating, and it can go wrong and potentially make cancer cells, because the cancer is an acquired genetic disorder. So people ask me, say, well, what does that mean? Does that mean I was born with it, I'm going to pass it on? Well, all cancers can be familial, most aren't, but there's this potential when you make a new cell that you can make something that's genetically abnormal, and therefore it could be a cancer cell. So this process is going on all the time in everybody. And most of the time your immune system can recognize that's going to be a cancer cell and get rid of it, but it doesn't happen always as well as it should do, and therefore by chance you can make cells that could become cancer cells. And so you've got this continuous battle between, this is sort of the development here in a cartoon of cancer cells, these epithelial cells in this context that are growing out of control. All these other cells shown here, these are T cells and NK cells, these are parts of your immune system. These are the immune killer cells, and they're recruited to try and get rid of it. And you can end up in an equilibrium, small amounts of cancer cells that are there, and which wins? Is it the cancer that grows and you get escape and it grows out of control? Or is it the immune system that wins, or does it sort of stay in a balance? So actually the development of cancer, including CLL, is almost a random process that's occurring, that we are making cells that could be cancerous and grow too quickly. Your immune system's trying to control it, and it's which one wins. And there's a very clear association between the immune system and cancer. So Advanced HIV was a good example of this. So in the 1990s, before good HIV therapy, there was a large spike in some types of lymphomas. It wasn't CLL, but high-grade lymphomas. And this is because if you have HIV, your immune system is weakened, so therefore you've got less immune surveillance. You also get more infections which drive which drive the development of blood cells. So you've got more proliferation and more cells being produced, less immune surveillance, and therefore more lymphoma. And actually what we're seeing with high-grade lymphomas in the pre-antiretroviral AIDS are about 400 or 500 times more common than the general population. So it just to illustrate this interplay between the immune system and cancer development. So as I said, it's this sort of process that's occurring, that you've got all these mutations that are occurring by chance, which influence the DNA being the genetic material that we have in all of our cells that makes them do things that can lead to cancer. And there are some things that can make it more or less likely. Some people will have a family history. With CLL, for example, maybe a few percent of CLL is familial, but most CLL patients are the only patient in their family that's ever had it. But there can be a broader, if you sort of look at it, some families have heart disease, others will have cancers. Maybe it's, my dad's got prostate cancer and I've got CLL and my aunt had something else. There's not a direct link between them, but it points to the fact there's probably something in the way they're put together that means that their body is more likely to make abnormal cells or less able to deal with them. And then there's environmental things. So smoking, radiation, chemicals, a whole bunch of things that can then make more mutations. And it's that balance of what you're born with, the chance process of going through life and making cells, and then what you expose yourself to in terms of that can lead to cancer. And this just illustrates the sort of, when people say, why don't I have cancer? How many blood cells do you make every day? That's daily production of blood cells in everybody. It's not an exaggeration. 200 billion red cells and 10 billion white cells. That's not all lymphocytes. So I guess we can say, well, if you're making 10 billion cells that could be cells every day, times every day of your life, it's amazing that we don't all get problems. But it does illustrate the fact that if you live forever, eventually this causes a problem because just by chance this is going to occur. So in terms of the risk factors for CLL, this doesn't really explain in terms of things aren't necessarily reversible. It is a disease that is predominantly seen in older life. So it is more common in men than women, as with other types of lymphomas. There can also be racial differences, a bit of in the sense that it's very uncommon in South Asia, for example, more common in the Western world. This is around immune function. As I've said, a proportion of people may have a family history, and there are some putative associations with pesticides and things. But I mean, the association there is fairly weak. But I think that what I always tell people that come and see me, it's not your fault. There's nothing that you've done. It's nothing that somebody's caused. And there's almost certainly nothing that you could have done about it that would have made a difference in terms of why you've got it. Not much consolation, but equally, I suppose it does come. Don't beat yourself up in terms of looking for it, of thinking that if only, if only, if only. This is a chance event. The gloomy bit, we're all ticking bombs and something's going to happen. So coming back to the demographics of CLL and how we investigate it and stage it, this is just to illustrate how many cancers are seen in the UK every year. So this is data from CR UK, Cancer Research UK. One of the things in terms of this was some work that's been done with, say, Blood Cancer UK, is that all the blood cancers individually are relatively uncommon, but if you bundle them together, blood cancer is about the 5th most common malignancy seen in the UK. So you can see here that at the top, we've got breast and prostate cancer being most common, lung and bowel, and then blood cancer, the 5th most common, with around 30,000 patients per year. And the green bar here is just how many patients are diagnosed with CLL in the UK, which is about 4,000-ish per year. One of the things, though, that's important, and people may talk about this represents incidence. Incidence is the number of new cases per year. What it doesn't capture, though, is the overall burden of who's living with CLL, which is prevalence. So this is the number of people in the population. As you're aware, most people with CLL, I'll come back to this, are diagnosed with early stage asymptomatic disease, and they have it for a long period of time. So although it's 4,000 patients per year, the prevalence in terms of how many people at any one time are living with CLL is at least 10 times higher. So therefore not as uncommon as it might be, although that's the number per year, but at least 40,000 plus people living with it at any time. And as we diagnose more of it, because people have more blood tests, that number is probably an underestimate. This shows incidence over time, so and also by sex. So in the middle here, you've got the number of cases per 100,000 of the population per year. More in blue, which is men, less in women, but overall, a relatively static incidence over the last 30 years of about 5 or 6 patients per 100,000 per year, which equates to about 4,000 patients a year diagnosed in the UK. And this shows the demographics in terms of age. So this is looking at the number of cases per year that are diagnosed as a factor of age. This is from about 2020, again in the UK. And what can be seen here, the light blue lines, this is at any age range, are men. The pink lines are women. So at any given age, we see more cases diagnosed in men than women. The cumulative age comes up here, so it becomes more common. As you get older and older and older, you see more cases per year. If everyone lived forever, it would keep going up. Of course, it doesn't. When, of course, you then look, there are fewer people living who are 90 plus than are younger. What we end up with is the peak incidence here is around early 70s, somewhere between 70 and 75. It's relatively uncommon under the age of 60, but about 15%, so 1 in 6 CLL patients is under 60 in diagnosis. Very uncommon below the age of 40, but certainly have a few patients in my clinic who have been diagnosed in their 20s and 30s. So that is what it is. So CLL, a chance event of making abnormal lymphocytes, white blood cells, predominantly seen as a factor of aging, more in men than women, and in terms of risk factors, there are some things that make it more likely. So in terms of then, how do we stage it? So the majority of people diagnosed with CLL, and it hopefully resonates with people here, it's an incidental finding. It's a blood test or a lymph gland. I went to the doctor with an earache. He said, let's do some blood tests. And I came out with a garbled diagnosis of mild cancer. Don't know quite what that means. Go and see the hospital. It's not so bad. It's the one to have. All this kind of nonsense. But anyway, so, great. If it's the one to have, you can have it, So, but it is something, this is the way it's diagnosed. But once the diagnosis has been made, next stage is how much have you got, because this is really, really important in terms of what you need to do about it. It's important, I always tell people to contextualize it, of going, if you've been diagnosed with CLL, it's a slow growing thing. You've had it for a lot longer than you've known about it, and actually you were all right yesterday before you had this news, and you were all right a year ago. You're all right today. You're not suddenly going to become unwell or have lots of symptoms in terms of things. But it is important to understand the amount of disease that you've got, and this is the stage. So there are 2 systems that can be used to stage CLL. The Rye system from Canty Rye, so much beloved of Americans, he being American, and the Binet system from Dr. Binet, developed in France and therefore used in a sort of very parochial way in Europe. They both tell you similar things. So in the Rye system, which we don't tend to use so much of, stages 0 to 5. And this is based on the fact that at an early stage, you just have an abnormal blood count because it's the most common thing that's seen. As the disease progresses, more lymph nodes, the spleen or liver becoming enlarged, and then the bone marrow not working so well. So as CLL develops, it starts to make abnormal cells to the detriment of the normal ones. So the white count goes up, the hemoglobin red cells go down, the platelets drop. And similarly, but different, the Binet system, A, B, and C, rather than 0 to 4, is predominantly around the distribution of nodal disease. There isn't a complete overlap here, but less than 3 nodal areas. And we define nodal areas, I showed you before the map of where nodes are. So in your neck, in the cervical region, would be a nodal area. Above the collarbone, supraclavicular is an area, axillary is an area. So it's how they chunk them up rather than 3 individual lymph nodes, more than 3, or then progressive reduction in blood counts. This doesn't make a reference, this kind of assumes that everybody has, it doesn't make a reference to whether you've got a lymphocytosis, unlike the Rye system. But they both tell you similar type of things. And in terms of how it is, less is more. You know, the less you have of this, the better. Early stage does better. Most people are diagnosed with early stage disease. And the pattern of CLL has changed. So this is 10 or 20 years old now. So this is from a presentation when I gave this 20 years ago. But anyway, so these are data from Barcelona, so the big CLL group. And they just looked at what proportion of their patients were diagnosed, it's in Europe, so it's ABC, with stage A, B, and C disease. And what you can see with this, if you go back 50 years, a significant proportion of people up here were diagnosed with stage B or stage C disease. Only 40% or so with stage A disease. This is a reflection of 50 years ago, people had blood tests done or had things done when they were unwell and went to the doctor because it was guided by that rather than being pulled along to have your blood pressure measured and having a blood test done. If you then jump forward to the 2000s, in their series, 80% of people were diagnosed with stage A disease and only a relatively small proportion with more advanced stages because of earlier screening, more blood tests was what was done. So the pattern has changed, different centres have shown different things, but again it underpins the fact that most people diagnosed now have earlier stage disease, and that's that important for that context question about the fact that most people with stage A disease don't have a lot or have very few symptoms. Oh, hang on, where are we going? A note about CLL versus SLL. So remember I said to you that we're talking here about the growth of lymphocytes. They are the same cells. You have lymphocytes in your blood. That's another CLL picture. Showed there before. There's no smear cells on that one, but they're just typical picture. And you have lymph node enlargement. Leukemia just means white blood. That's Latin. So, and most people with CLL, if you look hard enough, will have some disease in their blood that you can see. A few people with CLL will just have disease in their lymph nodes. Although actually, if you looked in the bone marrow, almost, I think without exception, everybody will have some disease in the bone marrow, but it might not come out into the blood. So leukemia is a term we use for talking about liquid disease. You can see it in the blood. Lymphoma, a term that's usually for lumpy disease in the lymph nodes. And the classification, unhelpfully, gives 2 classifications here, chronic lymphocytic leukemia and small lymphocytic lymphoma. So that's being shown here, blood, and that's what a CLL lymph node looks like if you took a section of it. They're the same. So there is no distinction in terms of prognosis or treatment. CLL equals SLL. And in terms of how it should be correct, SLL is a subtype of CLL, so I always refer to it all as CLL, but I wouldn't be the first person who's come along to see me. We're okay, we get on, sitting halfway through the conversation, I then go, well, I'm talking about leukemia now. It's like seeing their face drop. It's like, oh my God, I've now got something else. Now I've got something that's really serious. They're the same thing. How do you make the diagnosis? Well, as I said, it's lymph nodes it's an abnormal blood test. You can look at the blood film and maybe see some smear cells. You get an idea that this is going to be the most likely diagnosis. But there are lots of different, I said to you before, there are lots of different stages of lymphocyte development, and each of those stages has a leukemia or lymphoma counterpart, and some of them, it's semantic differences, but there are some quite important differences here between cells that might look the same, but actually one of them's CLL, another might be a different type of leukemia or lymphoma, which can have bearing both on prognosis and on treatment. And the way that you make a diagnosis in terms of nailing it down is by interrogating what's on the surface of the blood cells. So you'll have heard of blood groups, red blood cells. They have things sticking out the surface of them that tell, well, in fact all cells do, that tell your body what type of cell they are, and is it yours or is it somebody else's. And there's a whole load of things that stick out of cells. Red cells, it's the simplest thing. There's A and B and rhesus. There are actually 27 blood groups, but they don't matter so much. And they just allow you to then match and say, well, I've got A, they've got A, therefore we can then transfuse. With white blood cells, it's more complex and there are more things that stick out the surface. And what you can do is to interrogate those things on the surface of the cells to say, is that a normal cell or an abnormal cell? Because there are patterns that you see to say, is it a lymphocyte or is it a myelocyte? There are also patterns that you can see that say, is it a normal happy lymphocyte or an abnormal CLL lymphocyte. And those markers are called cluster designation markers, CD markers, and there are hundreds of them. And if you take, this is a bit of lymph node, I think, and what happens here is you have an antibody. So antibodies are specific molecules that you can generate, let's just say against CD19, which is expressed on CLL cells. And you stain it so it goes and sticks on the CD19, and then you put something on it that glows or has a color on it so you can see it. And this is immunohistochemistry, so this is a bit of lymph node that has been stained with an antibody that's then got an enzyme that causes a color reaction to then be able to see this brown thing to then say, these cells all express whatever. And that allows you to then say what sort of cells you are. In blood, we do it differently with what's called flow cytometry. So when you have a blood count done, a blood count work, well, first thing is that a blood count takes 45 seconds to do. So whatever you get told in your clinic about, ooh, well, it takes a long time to do a blood count, sorry about your delay, it's the lab. Nah, that's not right. It doesn't take long to get a blood count done. But what it does is it takes the blood and it puts it into a single file and it runs it through, and then it interrogates those cells by doing something to them that says how big or how small or what they are. Flow cytometry is a clever way of doing a blood count, and it's reliant on these antibodies again. So you take, right, we want to say there's 5 antibodies that you can use that will allow us with a high degree of certainty to say, is it a CLL cell or is it normal? And so you put 5 antibodies on the cells, and you put what are called fluorochromes on them, which are fluorescent chemicals, and they have different colors. And when you shine a laser at them, it allows you to determine whether it's red, orange, green, and what they are. So this is sort of schematically how it is. You've got your cells here, which have all been labeled with antibodies that are all slightly different. So that might be CD5, which we've put a red fluorochrome on, and that's CD19 with a blue, and that's CD something else. You run them down in a straight line, so you take your blood and it's running very fast through it. A laser is shone on it, which allows, and it pings off that one and says, right, I recognize that's red, and that's yellow, and that's things. And then you can then separate them, because you know, are they red or whatever. And you can then decide how you plot one against another. So what you can see, for example, is this is a plot that's taking all of the CD19 cells. Now this is a B cell marker, so it should be on all your B lymphocytes. And then that is doing it against CD5, which is a T cell marker. So normally speaking, you should have 2 populations. B cells express CD19, T cells express CD5. And they shouldn't co-express together. And what you can see in this case is that you've got this population of cells here whereby they're expressing both CD19 and CD5. That shouldn't happen in health. That doesn't happen in healthy cells. So it allows you to say you've got a population of cells that are expressing both those markers, and that's very characteristic of CLL. And you can do other things if you want to do CD whatever versus CD whatever, and it allows you at the end of it, hopefully, to get something that says this population of cells looks like CLL. Sometimes it can be difficult to distinguish one from the other, in which case you might have to have more detailed testing or a bone marrow biopsy or something else done, but you can usually nail it on that test without reverting to it. So coming back to, if anybody suggests you need to have a bone marrow biopsy, please ask them why. Historically, we used to do bone marrow biopsies in everybody with CLL, and it mostly tells you what you already know. So your blood comes from your bone marrow. If you've got CLL in your blood, you've 100% got it in your bone marrow because that's where it's coming from. But finding it there, which is, those who've had it, not the most joyous thing to do, doesn't actually add any value. So there are reasons whereby you might want to do a bone marrow. For example, we can't nail the diagnosis. We don't know, is this CLL or is it mantle cell lymphoma or something different? It may be the same. We're worried about you've got low blood counts. We need to know what's going on in your bone marrow. Is it all put together? So there are reasons, but as a diagnostic routine test, it's not necessary to do a bone marrow biopsy. As I said to you, CLL is present in your blood, your bone marrow, and your lymph glands. Most of the a lot of lymph glands you can feel, but the presence or absence of lymph glands is not a reason to do anything different about it. And you can do scans to see, have you got enlarged lymph nodes on the inside? So this is what a CT scan looks like. So if you imagine this is a patient who is lying down, their head is somewhere in the wall, and their feet are here, and they're lying on their back and taking slices through this microphone like that. And we're doing this about that region, middle of the chest. So that is the manubrium, the breastbone. That's the front, that's the back, that's the spine. The ribs are these bits in white, lungs in black, and that's the heart in the middle. And this is a patient who had not very much abnormality. As they did have another CT scan done because they've progressed, and this showed here, you can see you've got this lump that's developed, which is asymmetrical, and that's a lymph node lump that's sitting there, and then it has some treatment and it went away again. So it does provide information to be able to follow what's going on with things and diagnostically, but as a routine test, I wouldn't recommend doing it at somebody who's just otherwise well and doesn't have any other worries about, any other concerns, because it tells you what you already know. And if you have a CT scan of your whole body, it gives you about 5 years of background radiation, which on a big scheme of things, I mean, it's not, I don't want to overstate the risk of having scans, but there is a downside. Statistically, you have a 1 in 2,000 chance of getting cancer if you have a CT scan. And so what can then be, I've seen, is where people then go, well, I had one, but then I'm going to have another one, and then another one, to see how it goes. And then they've had 10 CT scans, all of which might be terribly reassuring, so there's not much going on here, but actually you've ended up with a lot of radiation. So imaging can be necessary, particularly if you're thinking about, has somebody got big lumps and it might make a difference, or you're worried about other reasons, but routine imaging at diagnosis is not something I would recommend. The other thing whereby you might get this is in trials. So in trials, because it's very important to be able to accurately follow exactly where somebody is, they often mandate having regular CT scans. But I'd ask the question about that, because you can end up, if you're in a trial that lasts 3 years and you have a scan done every 3 months, you're going to get 12 CT scans. What's the added value, what's to think about? But it's something to think about in terms of risk-benefit. So then, lastly, genetic testing. As I've said, CLL, like cancers, is an acquired genetic thing, so disease. Everybody with CLL will have a genetic mutation, without exception, because CLL cells are genetically abnormal, which is what makes them CLL cells and not normal lymphocytes. This is how genes are packaged in your cells. So genetic code is in DNA. So this is if you stretched it out, it would go around the world several times, the whole string of genetic material, and it's then condensed. So the DNA code, it's like packaged up into what's called chromatin. It's then into chromosomes, which are aggregations of DNA, and then that all sits in the nucleus of the cell. So the DNA is all packaged away, but it's not just a sort of random squiggle, it's in defined structures, which are the chromosomes. And so if you want to look at tests, and you may have some of these done, or when do you do them, there are a number of things that can be done. The first is FISH testing. What does FISH testing stand for? Fluorescent in situ hybridization. So this is a test which you will see abnormalities in about 80% of CLL cells. You can identify big bits of DNA that have moved around in their cells. So you can take the cells and you can smash them up to look at the chromosomes, which are the condensed bits of DNA, and then you can then, similarly to what I talked about with flow cytometry, you can put an antibody on, or something that is fluorescent that you can then look at. And this allows you to then see what the chromosomes are like, and have they moved around? Have you had bits that have switched from one place to another? Because if you did, for example, or have you got a loss of a bit of a chromosome, something's lost, or have you got bits that you've got extra copies of things? So the FISH result, you can then interrogate it, and this is just showing you can put different colours on for different chromosomes. So I want to look at chromosome X and chromosome Y, look at it on the cell, and you get, that's what it looks like. And this is what you see in CLL. So these are real CLL things. So that is a case of, you've got here, so we're looking at, this is a control, so this is chromosome X, so you've got 2 copies, because you have 2 copies of each chromosome, and that's looking at chromosome 17. That's where P53 sits. So on this, you can see you've only got 1 copy of it, so you can see you've lost that. In this case, the colour's the other way around. The green is the X, and then this is looking at chromosome 12, and you've got 3 copies of it. So that's a loss, and that's an addition. So that's something you can see, recurrent abnormalities with chromosomes, whereby bits, during that random process of making cells, the genetic material, it gets mixed up. Things get stuck together that shouldn't be, something gets lost, something gets added. Things, though, have moved on. So I did my PhD in the late 90s, early 2000s, and this was about the time the genome was sequenced. So the genome just describes the whole of the genetic material in your entire body. This took 10 years, 2 groups, one in the US, one in Cambridge, and £100 million or dollars to do it. And it was a big thing, a big splash. The genetic code of life has been cracked. 1 genome, 1 patient, 10 years. Now, if we just skip forward now, and you want to say, I want to know all my genetic information, I'd like my whole cancer genome done. I'd like to have all my 17,000 genes sequenced, 2 terabytes of data, 500 quid in 4 weeks, or something like that. So it's a routine diagnostic test. And what this means is that rather than looking for great big bits of DNA that have moved around, which is FISH testing, which is helpful but is quite insensitive because this is looking at very large bits, you can now get down to the single encoding sequence in the gene sequence. So this allows you to do things like saying, I'm going to look at a particular bit of the DNA. So in this case, this is the code, A's, G's, T's, and C's. This is the DNA code. And now you can actually get down to the point of I can look at a single mutation. That might be all it is. 1 base that's flipped from one thing to another thing that stops that gene working properly. And this is an example of what you get when you get NGS testing. That's next generation sequencing. So this is being able to sequence genes at the level of precision where you can get down to individual base pair things. So we get complementary information now. So you'll get told, well, you've got FISH mutations, which are big things, but also specific mutations on specific genes. We don't look at the whole genome for everything because not every gene is mutated in CLL. 17,000, but actually you only need to look at about 20 or 30. But you can get to the point, just looking at those 20 or 30, of real high precision in terms of very specific things, looking for those mutations. And then the third thing is IGHV sequencing, which when I speak to my trainees, they all confidently say IGHV sequencing, and they don't know what it means. So just in terms of why this is important, this is another prognostic factor. As I've said to you before, lymphocytes are part of your immune system, and they make antibodies, part of your immune system. They're like your immune memory. When you have a vaccine, you make a lymphocyte, it makes an antibody against the vaccine, it remembers it's seen it before, see the infection, makes the antibody, and then it gets rid of it. And that is encoded by genes. So antibodies, this is a schematic of what an antibody looks like. And you've got two big chains here called heavy chains, they're the big ones. And you've got two light chains, which are the light ones. And the antibody is kind of Y-shaped. And that Y bit is variable, so that changes shape. So that can be anything you want. So you make a different shape Y to whatever it is that it's trying to bind onto. And the heavy chains and the light chains are encoded by bits of DNA, the heavy chain IGHV immunoglobulin, which is antibody heavy chain sequence. And that is something that, unlike normal gene, most genes you've got one copy and it's genetically the same. It has to be. You don't want random things because if you introduce mutations you get cancer. The immunoglobulin genes have to be variable because if you don't, you'd make all your antibodies exactly the same. They have to be variable. And so this sequence can be mutated or unmutated. So when lymphocytes are born, coming back to remember, say, lymphocytes, they go in your bone marrow, blood, they go to the lymph nodes, they come back to your blood. So some lymphocytes, these are baby ones, they haven't seen anything, they haven't met, I don't know, the environment, they haven't met antibodies, they haven't met infections. And these are called unmutated cells because they're all the same. So these are the ones, so when it happens, that sequence here that makes an antibody, it's all the same because they haven't gone through that process whereby it's kind of randomly changed to make it a good antibody or not. They then go into the lymph nodes where they meet the world, and the ones that are good and are going to fight something you want it to, they go through that mutation process and they come out, and the best fit come out as mutated cells. So you've got two different types: baby lymphocytes, unmutated; mature lymphocytes are mutated. And you can generate CLL from those cells or from those cells. So unmutated cells, which is about 40%, are a bit more difficult to treat. Mutated ones, which is 60%, have a better prognosis. So this is another factor that can be looked at, and things that you may or may not get talked about in clinic in terms of, I've done your FISH testing, your NGS testing, your IGH sequencing, and this is what it means. I don't know if I've made any clarity there, but this is why you do the tests in terms of doing it and what it means, because these are prognostic. Why do we do it? Because coming back to, you've got CLL patients. Someone has 20 years and never needs any treatment. Someone ends up being treated after 1 year and unfortunately maybe the treatment doesn't work. And the reason for that is that the genetic way that you get CLL varies, because I've said it's a genetic event, but it's not the same genetic event in everybody. So it's one of the reasons whereby some people will do much better, some people will do worse, because they have a different pattern of genetic mutations which alter the prognosis and also alter the treatment. So how do you then use this information in somebody who's just been diagnosed? Well, simply speaking, I wouldn't do any of this test if you've just been diagnosed generally, because it doesn't actually change what you do about it. Coming back to that context, you've gone into the GP, you're well, you've got a slightly abnormal blood count, maybe a lymph node, you can do all this stuff, but you're going to walk out of it being told, not going to give you any treatment. Where it's really important is around choices of treatment, which I'll come to in my next talk. But where it can be, and I think this is one whereby it's individualized in terms of something to think about, it's a conversation to be had, is does it change my prognosis? Now, this is an individual thing, and this is about this sort of shared decision-making in terms of, I've said to people, okay, the information about this testing doesn't actually help me because it's not going to change my treatment. But if you tell me, well, actually it might change because I don't know whether I want to buy a new house, or am I going to take the promotion, or am I going to just get on, do things differently? Can I get a life insurance thing? What am I going to do with the rest of my life? These tests do help looking at prognosis. So if you look at prognosis by this genetic testing things, overall, for somebody with stage A CLL, how long is it before they're going to need treatment? 5-8 years on average, something like that. But it does vary depending on this genetic mutational landscape. So you can see here, this is FISH testing. I already talked about this. So the loss of chromosome 17, which leads to a loss of P53, that's quite bad. So on average, this was a series from 20 years ago, most people there needed treatment within 1 year. For those people who'd got a loss of chromosome 13, they mostly didn't need treatment for 10 years. The mutated versus unmutated. The unmutated baby CLL cells mostly will get to treatment sooner than those patients who've got mutated CLL. So it isn't unimportant, it doesn't change what you do, but for those who want to have a conversation about it and somebody's saying, no, the guidance says don't do it, well, that's true, but I wouldn't do it for everybody, but I'd certainly have a conversation about it in somebody who says, that information actually is very useful to me. And you can bundle these things together a bit more in terms of trying to work out, if you've just been diagnosed, how long is it until I might need treatment? Because it's like, what's the importance? You get lots of information from different tests. And so there was a couple of scores that have looked at this. So these are taking a population and then seeing if you look at different factors, can you then determine how people might do. So the IPSE score, this was published a few years ago, this divided CLL patients into 3 groups, about 1/3 in each group, and they looked at all the factors, so IGHV, FISH, age, blood tests, whatever, to see how long before they needed treatment. And they found that the IGHV mutational status, the lymphocyte count, and the amount of nodes, this is essentially the stage of disease, were the things that made a difference. So if you had none of those factors, then your chances of needing treatment after 5 years was less than 10%. If you had all of them, it was 2/3 of people. So this can be important, and I think that it's a conversation just to have about the fact of, is that information going to be helpful to you as an individual? This was another thing, doing a similar thing, so looking at the CLL, this was from CLL1 to the German group. They looked at different factors in their group. IGHV was there, deletion of 17p, 11q, and some blood test factors. Again, you got different points. So rather than 1 point, some of them gave you were more. So you got 3.5 points for 17p deletion, but only 1.5 points if you're older. They divided into 4 groups. And again, similar pattern. If you had none of the factors, which was 2/3, the average time to needing treatment wasn't reached, and they did very, very well. And the 5-year overall survival was getting on towards 100%. Whereas if you had all the factors, then you can see that shorter duration to treatment, most patients needed treatment within 2 or 3 years, and survival was less. But that was only in a very small minority of patients. So I think my take from this is these things are important. They tell us about the biology of the disease, and they also tell us about prognosis as well, but they are not necessarily tests that are offered or relevant or necessary for everybody. So in terms of conclusions, I've banged on a bit here, I'm sorry, but it's a slow-growing disorder. We've talked about this concept of cancer being an acquired genetic disorder that's informed by genetic risks, environmental risks, and chance. CLL is most commonly diagnosed in older adults, and it's mostly made by examination of blood, and we talked about flow cytometry there, remembering CLL and SLL are the same. And all the disease, if you looked and did that genetic testing, everyone with CLL has genetic mutations. But at diagnosis, the utility of those tests is something I would say is to discuss, and it's individualised. Right, I'll be quiet. That's it. Thank you.
Thanks, Adrian. A couple of questions, actually. One relatively straightforward, the other a little bit more involved. Firstly, do your figures, the incident rate figures for CLL, include SLL?
Yes.
So they do, correct. And the second question, what is the significance of an accelerated CLL, SLL diagnosis, and how does this likely affect the prognosis and treatment?
Yeah, okay. So when you look at CLL cells, they mostly look small and mature, and they're slow growing. What I haven't shown you is that there's a spectrum of disorders that can happen whereby the cells start to grow more quickly, and what they start to look like are what are called pro-lymphocytes. So it's where the cells are proliferating more rapidly, and eventually that's something that includes a spectrum that turns to Richter transformation, which is where the CLL has morphed into a high-grade aggressive disease. So there is prognostic significance if you look that if you have accelerated cells, it grows more quickly, and it can be associated with some of these adverse genetic risk factors. So at diagnosis, doesn't make a huge difference, but it might be one I would want to watch a bit more closely. It's something that when you get to treatment, that might be less effective. On a more positive note, though, lots of the things that were associated with treatment resistance with conventional chemotherapy, you can overcome to some extent, at least, by using targeted treatments like BTK and things like ibrutinib and things.
When I was diagnosed 2 years ago, I was also told that I had high cholesterol, and I was just wondering, which hasn't come down, is there any research or evidence to suggest there may be a correlation with CLL?
No, not directly. I think, though, in terms of the question I always get asked after a diagnosis, what can I do? Because of, can I change something, my diet, exercise, this type of thing. All of these things play into general health and then also into how well people sort of do with treatment and generally. So not so much worried about cholesterol particularly, but I think it does underpin the fact that managing other health conditions is also really, really important. And all the things that people will talk to you about, like exercise more, cholesterol, blood pressure, smoking, diet, alcohol, become that much more important when you've got CLL because of the fact of you're probably going to need some treatment, and therefore it's going to be important. But there isn't, as far as I know, a direct association. There are all sorts of weird genetic associations we look at and say, but it's two unrelated things.
Is ZAP testing routinely available in the UK?
Routinely, no. You can get it done. So there were a few. ZAP70 testing was another one. There are all sorts of markers that have been done. So ZAP70 is another thing, like it's a T cell marker that becomes on B cells, and there were some studies that were done more than 20 years ago that showed it was also prognostically significant. It's not one that has, its importance has waned in terms of where it sits. So it can be done. It is sometimes done in trials, but you would struggle probably to get it done in a routine hospital, and it's not something that I test.
We're in September, despite it being a lovely day. Winter is approaching, and vitamins.
Yeah.
And, should people be taking vitamin supplements? I know in Scotland during the pandemic, where I live, we were given vitamin D.
Yeah. That sort of worked its way down to here as well. So it's still pretty dark in the winter. So, and there was a weak association with the COVID that vitamin D might make a difference. I think that was sort of eventually debunked. We've looked at vitamin D deficiency in our patients at the Christie, and 50% or more, I don't know. The more I look, the more we find vitamin D deficiency. It's almost endemic. And again, I don't know that it makes a massive difference in terms of how the CLL develops. It's certainly good for your bone health if your vitamin D is there. So I think that taking vitamin D supplementation is a very reasonable thing to do, because the population in the UK in the winter, many will end up being vitamin D deficient. And I think it's, again, coming back to the previous question around cholesterol and things, that as you get older, bone health drops, particularly if you're female, and therefore it's a reasonable thing to do. But equally, I would love to have the answer that said, take this, it's going to alter the natural history of the disease. And I try not to be too cynical about it. You know, if somebody comes along and says, I'm going to eat this, I'm going to have blue food, and I'm going to have coffee enemas, and I'm going to have CBD, and I'm going to take vitamins and do this. If it's not something that's going to make me worse, I mean, I can work with it, it's fine. I mean, I just wish that I could say that there was some evidence that had been really shown that made a huge difference, that showed that it improved the outcomes. And unfortunately, there isn't. And it's not because I'm just betrothed to drug companies and all I'm interested in is doing it. It would be great. I would love to never give somebody chemotherapy again, but it's just the fact that there isn't there. But sorry, it's a long answer to a short question. But yes, vitamin D, it is a thing, but I'd recommend taking it.